So what we're going to cover today is a bunch of points, but what I'm hoping that you'll take away from is how to apply an evidence-based instrument to identify youth at risk for suicide. And we're using the Columbia Suicide Severity Rating Scale, which has evidence basis in adults as well as youth and adolescents and school-age children. And we're going to talk about how to use that to make some kind of assessment about what's the most appropriate care for someone who presents at risk. Then we're going to look at, in greater detail, about safety planning. And safety planning includes lethal means counseling, which we'll also go into at length, for youth at risk for suicide. And then for today, we're emphasizing about the importance of having good and accurate assessments and communication when youth come into emergency departments, emergency rooms, urgent care clinics for an assessment about the benefits and the detriments and the necessity for an inpatient hospitalization or not. The reason that we're really emphasizing this is because there's a lot of research in the last few years that the most dangerous place for someone who is suicidal to be is not when they are hospitalized and not before hospitalization or before being seen in an emergency department, but when they're discharged back to the community. So even if they have a relatively lengthy stay in an inpatient unit and are seemingly stabilized, they're at highest risk for killing themselves in the month or so after they leave the hospital, much less after they leave the emergency department. So that's why we want to emphasize careful assessment and the importance of inpatient providers and urgent care providers and emergency department providers about giving good information to the youth, their family, to the schools, to all their systems of care, so that people can provide really good services for people at risk once they are not hospitalized or leave the hospital. Another piece of this is one of the greatest ways that we can prevent people from killing themselves is to reduce access to specially loaded firearms and make sure that they're supervised so that they don't hang themselves, suffocate themselves, etc. People are much more likely to die from an attempt if the attempt is made with firearms or ligatures or hanging or jumping. Much less likely to die from overdose and from cutting. So we're not terrifically great about predicting suicidality, and we may not be able to intervene in the moment. As we'll talk about, suicidality and the impulse to kill yourself is often within minutes. It's not something that builds and builds and builds over time with careful deliberation and planning and attempts. So if someone feels very much hopeless and helpless and worthless and feels like the only solution to end their misery in their mind and in their foreseeable future is to kill themselves, if they don't have access to a way that is highly likely to result in their death, they won't die from the attempt. And by the time they conduct their search for drugs that might kill them or looking for firearms, etc., that intense intent and motivation to kill themselves significantly declines. And so they're less likely to die and they're less likely to reattempt. So that's why we're emphasizing those things from a public health standpoint. Next slide. This is just the typical disclosure, no financial relationship to what I'm talking to you about. Next. This is just going to be a brief review about the unfortunate fact that New Mexico, in a lot of comparisons across the country, has the highest rate of suicide in the United States. And there's many reasons for that. We're one of the most impoverished states. And we're impoverished not just in the sense of poverty and lack of housing and clothing and nutritional support. We're also impoverished in the sense of resources. And so we have very little capacity in our state for behavioral health support and community support. And that is one of the major reasons why our suicide rate is so high. So these are some statistics for you. Again, you'll get the copy of this. So what I did, by the way, is made my presentation sort of fact heavy. And I'm going to rely on the fact that you're going to get the PDFs to review all this at greater length when you have the time. And I hope that this will be a very useful resource for you. I have a lot of references at the back. Next slide. So every category defining the cause of death: falling from a great height. One of the favorite places is in Taos, unfortunately. Firearms, poisoning, suffocation increased, but made up about the same percentage as the year before. These 2018 statistics are the most recent that we have. We also have risk factors of higher rates of adverse childhood events, which we know lead to significant both behavioral health and physical health challenges and concerns. And we have a high degree of gun ownership. And as I mentioned earlier, very limited access to behavioral health, especially in rural areas, as all of you know probably better than I do. Next. So one of the things that I wanted to frame all of these discussions that we're going to be having, and I hope you'll be able to join me in the coming weeks, and my colleague Laura Rombach, is that the pandemic also intensifies many of the risk factors for people at risk. I'm guessing that they're very obvious to you, but some of them is even more limited access to monitoring, supervision, care, and support. Economic challenges: there's a lot of people who are now facing eviction and homelessness. A lot of school children get their nutrition from school, and a lot of families lack the technology for virtual classrooms. We have all the anxiety about all the uncertainty, and like we know for schools, we've been through trying to have a hybrid model, face-to-face classrooms, and then there's some kind of outbreak, and then people are home again. Lots of uncertainty, lots of unpredictability, lots of stress, and lots of trauma. And then for all of us, when we try to do outreach, again, a lot of people have limited technology, poor wireless, poor connections for cellular phones. Home visits are not as possible because of COVID and the worries about infection. Social distancing, of course, increases social isolation. And a specific factor that we're really concerned about is, unfortunately, quote, home sheltering means that sometimes children or victims of domestic violence are sheltering, strangely enough, with their perpetrators. And we found out that the rate of reporting of child abuse has gone down massively, in some cases more than 80%. Same thing with domestic violence. So there's so many stress factors that are connected. And I just wanted to call your attention to this article that was published in the Albuquerque Journal in July, talking about an 11-year-old who had been doing really, really well. And then, as the mother says in the article, this young man, it was the end of the world when he was unable to connect to schools, peers, teachers, all those supports. And almost 6 weeks after his last day in the classroom, he killed himself using the gun his father had used at home to protect himself from rattlesnakes. And his death was, at that point in time, in July, one of more than 2,300 unexpected deaths that were analyzed by the Office of the Medical Investigator. So this is just to show that the total isolation from peers, from supports, from caring adults resulted in just significant depression. And he had very caring parents, but they were unable to mitigate against these awful circumstances for this young man. Next slide. So suicide for a long time has been the second leading cause of death for youth and young adults. And next slide. There we go. One of the things that I wanted to highlight again is that the vast majority of children, youth, adults, and people in the geriatric age range see providers other than behavioral health before they attempt suicide or kill themselves. So 50% of people who die by suicide had contact with their primary care providers in the month prior to suicide. 80% of people who die by suicide had contact with their primary care provider in the year prior to their death. Only 20% of people who died by suicide in this very large study saw a behavioral health provider within the month before they died. And 10% of people who died by suicide visited the ER within 2 months before they died. This is why, if we're looking at public health initiatives for prevention of suicide, we really want to focus not on behavioral health care, but on primary care, emergency care, and urgent care, because for a variety of reasons, that's where these interventions need to be made. Next slide. So comorbidity, again, you probably all know this, but 90% of people who die by suicide have a mental health disorder or substance use disorder or both. More than 50% of suicides are associated with the major depressive disorder. And what I want you to look at is within mood disorders, the statistics have not changed all that much in the last few decades. And that is that more people who have a major depressive disorder diagnosis attempt suicide. But as far as killing themselves, it's people who have bipolar 1 or manic episodes alternating with major depressive episodes. They're at greater risk for actually killing themselves when they make an attempt, fatal attempts. So approximately 25% of suicides are associated with a substance abuse disorder. This is increasingly important to look at because, as we know, there are a lot of people who unintentionally overdose and die. They had no desire to kill themselves, no intent, no plans, no behavior, no rehearsals, etc. So one of the things that I always want to call your attention to is all of the statistics about suicide attempts and suicides are underreported. And the reason for that is that for the offices of the medical investigator, whatever state that they're in, they have to have pretty conclusive evidence and proof that the death was due to suicide. And one of the examples that I give, it was a situation that happened, unfortunately, years ago in New Mexico, was a young man whose girlfriend was cheating on him with his best friend, their best friend. He found out about it. He had a history of drunk driving and alcohol abuse. Got into his car late at night when he found this out, drove the wrong way on I-25, made all the news, and died in that accident. And by all intents and purposes, knowing life circumstances and how he felt, it was a suicide, but it couldn't be ruled that way by the office of the medical investigator. Left no note, made no statement, had no assessment. So this is all to say that all these statistics that we're talking about are actually more horrific than is recorded in public health. Next slide. So thoughts of suicide, especially vague, unplanned thoughts like life isn't worth living, things are so tough I don't want to face the next day, I wish I didn't have to wake up, I feel hopeless, worthless, helpless, really miserable, are pretty common, especially in adolescence. Next slide. So one of the things I want to help you dispel is the myths, because they're all barriers to suicide prevention. So I'm going to go through them briefly because I want to spend a lot more time on the assessment, the safety plan, and lethal means reduction. So if someone is really suicidal, they're probably going to kill themselves at some point, no matter what you do. Asking a depressed person about suicide may put the idea in their heads. There's no point in asking about suicidal thoughts. If someone's going to do it, they won't tell you. Someone making suicidal threats won't really do it. They're just looking for attention. If you stop someone, they'll probably find another. All of these are totally untrue. So the issue is that the majority of people who survive a life-threatening suicide attempt, and in some studies it's as high as 90 to 95%, never make a suicide attempt that's remotely fatal or lethal again. So a lot of people who survive that life-threatening attempt, the majority of them never reattempt. When you ask a depression about suicide, you don't sort of hypnotically implant that idea where it never was. Again, in all the studies that we know about and in my clinical practice, and because how long I've been doing this, and I'm primarily in a supervisor of supervisor roles, I've had contact with hundreds and hundreds of thousands of youth over this time who've been suicidal. Everyone, when you ask, is relieved that you're asking the question. You're not implanting it in their mind when they never had it before. They're relieved that somebody else understands that they're miserable and that they're feeling hopeless. The only time where people won't tell you, it's a very small group, and that's people who are older adults, if not in the geriatric range, who've had a lifelong, chronic, unrelenting, major depressive disorder that is what we call treatment-resistant depression. They've tried everything. They've tried different forms of talk therapy. They've tried different medications. They've tried electroconvulsive therapy, transmit radiation, TMR, all sorts of remedies, ketamine injections. Nothing really helps. And so they're desperate. I compare it to people who have a terminal diagnosis of cancer and just feel that they should be given the right to have euthanasia because they don't see anything legitimately, any hope in sight. Those are the people who won't tell you because they don't want anybody to stop them from killing themselves because they don't know how to get relief any other way. So again, that's a very, very small group of people. Most people will readily tell you what they're doing. The idea about that you're looking for attention, those of you who know me know that this is one of my bugaboos. Attention means caring. When we talk about attachment, we mean that people attend to us. You're wanting me to attend to your needs. I'm wanting you to attend to our conversation and our collaboration with each other. It's human. So when we say somebody's doing it for attention, it's a way of being dismissive, discounting, pejorative, even stigmatizing. So I hope that you stop saying that adolescents are doing this for attention. It's a form of communication. And what they're saying is they need some kind of help. They need some kind of care. If you stop someone from killing themselves one way, they'll probably find another, like I mentioned, untrue. The reason it's really important for all of us to counter these myths is because a lot of people will say, I don't want my child or my student to be screened for suicide because that'll put that idea in their head where they never had it before. So please note, no support for any of these myths. Next. So I won't belabor this. I think you all know what a suicide attempt is. But the important thing here is that you have to understand what they understand. So I cite this all the time because a lot of people are, for instance, take pills that are potentially lethal and don't know that they're lethal and don't see what they're taking as an overdose. So take a young adolescent, father is taking medication to go to sleep, father is just as big as they are, takes 1 or 2 pills, and they are having a lot of difficulty going to sleep, so they take 4 or 5. They unfortunately have asthma, they have respiratory arrest, and they end up in the ICU. They had no intentions to die, but they took something that was potentially lethal. On the other hand, I've seen the opposite, where someone knows that Tylenol is really harmful to their liver. They take 4 or 6, thinking that the regular dose is 1 or 2, thinking that they will die from that, quote, overdose. And then people in the emergency room or urgent care or primary care will look, well, there was 100 tablets in the bottle. If they, quote, wanted to die and kill themselves, they would have taken the whole bottle. But in their belief, they thought they were going to be ending their life through a relatively small amount. So you really have to put yourself in their head, in their mind, and not do it objectively. So you don't want to dismiss the lethality of the second case because it was too low. And you don't want to assume that they were suicidal in intent when they weren't at all in the first case. Next. So now we're going to get into the 6 questions of the Columbia Suicide Severity Scale. And what we're looking at is ideas, their frequency, intensity, duration, a plan of what they might do, timing, location, lethality, availability, what they do to prepare, behaviors, past attempts, aborted versus interrupted attempts, rehearsals, and non-suicidal self-injurious actions. Now, quick pause here. What's the difference between aborted and interrupted? So aborted technically means in the literature, and we don't like those terms all that much, but that's what's used in suicidology. Aborted means that I'm in the middle of taking an overdose and I decide to stop. So I've stopped myself, okay? Interrupted is when I'm taking pills in the bathroom and my mom or dad or child or significant other, whoever it might be, knocks on the door and says, Avi, what's going on? I'm really worried. I haven't heard anything from you in a couple of minutes, sees me taking the pills and tosses it out of my hands. So it's interrupted by someone else. Now, the thing to think about is some interrupted attempts are aborted attempts. I'll give you one example that happened just a few months ago. I was meeting with a group of counselors in one of the schools to talk about what we're talking about today. And a knock on the door that one of the students was found in a classroom that was empty at that moment in time and had made a potentially lethal suicide attempt. Now, this student had been seen by one of the counselors for some time and had depression and intermittent suicidality. That student knew that all the classes were in session, that that classroom was empty at that moment in time, but that there were a lot of people passing by in the corridor, and that person knew that they were likely to be found and discovered. That would be very different if they used the same methodology in a park late at night when nobody was going to be around, nobody knew where they were, nobody could find them. So that's important when we're making our assessment. So for this young person, there was some idea, whether conscious or semi-conscious, that they wanted to be found and that they wanted someone to interrupt that attempt. So in some ways, it was aborted by themselves because of the situation they created. I'm belaboring this because I want you to understand that that level of detail is really important for all of us when we're making our assessments, and also really important for the people that we're passing on our assessments so they know how to plan for that individual. Too often, our assessments are denied suicidality, case closed, right? As opposed to all these different subtleties. Next. So now we're going to go into those 6 questions. And for those of you who are aware of this, there's the Trans-Theoretical Stages of Change theory by Prochaska and DiClemente, and motivational interviewing is in part based on that. That's the idea of when we're thinking about acting and doing something, whether for our risk or for our benefit, we have the idea not really in our heads, pre-contemplation. So everybody else tells me I have a drinking problem, but I don't see it that way at all. Contemplation is the next step where I'm beginning to say, you know, everybody that I trust and care about is saying, either you drink too much. So I'm beginning to contemplate, to think, maybe that's an issue, okay? The next stage is preparation, where I start to say, you know, it does affect my driving. My job is in jeopardy. Maybe it's a big issue. Maybe I should do something about it. So I'm preparing to act on what I'm thinking about, then action. So I'm actually going to do something. I'm going to get myself into rehab. I'm going to find someone who can facilitate my recovery. And then maintenance means I don't just make that one appointment, I have to keep following it up. So if we look at the suicide inquiry, we're talking about the barest kind of pre-contemplation, then contemplation, then preparation to act, and then action, which is the attempt or the rehearsal, etc. So the wish to be dead is also dependent on the developmental age of the youth and the child. So young children don't see death as universal or reversible, right? So they might have a very different understanding. They don't talk about wanting to die, but what they might talk about is going to sleep and never waking up. And another way that I rephrase that is when you look at tomorrow and the day after tomorrow, is it just like you just don't want to face it, you don't want to deal with it, you just wish that everybody would leave you alone, that you wouldn't have to do anything, that you just want to stay in bed, not wake up, not deal? That's the vaguest thoughts of life is not worth living and I don't want to move forward. Then you have non-specific kinds of suicidal thoughts. Have you thought about doing something to make yourself not alive anymore? Notice that phrasing for younger children. Have you had any thoughts about killing yourself for older children, adolescents, young adults. Next question. So then we're looking at any kinds of methods. So again, you're contemplating the possibility of how you might do this, but you don't have a well-formed kind of idea of what that might be. Have you thought about how you would do that, or how you would make yourself not alive anymore, kill yourself? What kinds of things did you think about? Next slide. So the active suicidal ideation with some intent, without a specific plan. When you thought about making yourself not alive anymore, did you think this was something you might actually do? Motivation. It's one thing to sort of contemplate, flirt with the idea. It's another thing to say, this is something that I might actually move forward. This is different than having the thoughts, but absolutely knowing you wouldn't do anything about that, right? So here, you might sort of have these scenarios develop in your mind, but you know in your heart of hearts that you're extremely unlikely to do that. Again, that level of detail is really important for all of us to understand. And then, have you decided how or when you would make yourself not alive anymore? What was your plan? Did you work out any kind of details? So the case that I just mentioned, that situation for the student at school, mapped out the method, mapped out the location, mapped out the timing, mapped out the possibility that other people would easily find out what was going on and interrupt or abort that attempt. That was very specific and very well thought out. Next. So these are the 6 questions in the Columbia Suicide Screen. Have you wished you were dead, wished you could go to sleep and not wake up? Have you actually had any thoughts of killing yourself? Have you been thinking about how you might do this? Have you had these thoughts and some intention of acting on them? Have you started to work out or worked out the details of how to kill yourself? Do you intend to carry out this plan? Intent? Have you ever done anything, started to do anything, prepared to do anything to end your life? Next slide. So as I mentioned earlier, some risky behaviors have no conscious wish to die, but they may result in death. Some risky behaviors have a conscious wish to die, but they may not result in death. In the first case, the person who accidentally takes an overdose of sleeping pills. In the second case, the issue with the Tylenol, thinking that a few pills would kill them, but fortunately, they didn't. It's also important for us to not have this binary idea of all we're looking at is suicide. We're looking at risk for dying, risk for death. And I always make this comparison because I think it's very sort of obvious in retrospect, right? But we have a situation, these are all true, with 6-year-old boy, massive history of child neglect and abuse, staying with a distant relative in temporary guardianship, poorly supervised, lives near the Big I, constantly runs into traffic and could get killed. No intent to die, no suicidality, no plans. If people would do this kind of assessment, they would say, no risk for suicide, but a very high risk for death. And that doesn't enter into the picture. We're just assessing for suicide. Second situation, 14-year-old young woman, long history in the family of mood disorders, both bipolar disorder, major depressive disorder, does not present with features of even mild major depressive disorder, but has intermittent kinds of depressive thoughts, ruminations, some ideas about her life is difficult, some feelings of worthlessness, helplessness, hopelessness. And so she admits sometimes to thinking very vaguely about life isn't worth living and maybe she should do something about it. Very low on this scale that we just talked about. She's seen as admitting, quote unquote, or describing suicidal ideation and at some risk. As far as risk for death, the 6-year-old very high, the 14-year-old very low. So I encourage you to think of this as a risk assessment, not as a suicidality assessment. Next slide. So now we're going to talk about the key risk factors, and this is evidence-based by the University of Washington group that originated dialectical behavioral therapy and the collaborative assessment and management of suicidality for youth that I will have the privilege of meeting with you in October, I believe, to talk about that. I hope you'll join me then. So what all these people talk about is not what other people say is risk factors for them, but what they identify for themselves. What makes it so difficult to move forward day to day. Hurt, anguish, misery in their mind, psychological pain, not physical pain. And when they talk about stress, what they mean is feeling overwhelmed, pressured, stressed out. Agitation is not our psychomotor agitation that we think about, but everything feels really urgent to them that they have to do something to end the misery and the anguish that they're feeling. Hopelessness, we all know, is a huge driving factor in suicidality. Thinking the idea, being overwhelmed with pessimism that nothing will ever get better, and worthlessness, self-hate, really disliking yourself. It's beyond having no self-esteem. It's all negative when you think about yourself. Those are the 5 major risk factors that have been identified, and that they're often the warning signals for folks to initiate their safety plan. Next. So one of the things that I want you to know is that there are a number of populations that are seen as high risk for suicidality. In most cases, they're stigmatized, under-resourced, discriminated against communities. And if those people feel supported by their larger community, their risks for self-harm and for suicidality are identical to everyone else. So it's really the fact of being in a discriminated, stigmatized, under-resourced group of people. And this is true for LGBTQA youth, that they are much less likely to do all sorts of risky behaviors, engage in risky behaviors, much less have a high degree of suicidality if they are brought up in supportive families, communities. Bullying is counteracted and prevented, and their strengths and resources, competencies are identified. This is true for AIAN populations, for a lot of people who are suffering from structural poverty. If those issues, those adverse events and circumstances are mitigated against or reversed, their risk factors are identical to all the other folks. Next. And I'm going to whiz through this because most of you work in schools and behavioral health, in nursing, I see. So you're well aware of all these other risk factors about comorbidities with mental health disorders, psychosocial stressors. But one thing that I always like to point out, because it sort of is mystifying to a lot of people who don't do physical health care, and I wear the hat of nurse and pediatrician as well as psychiatrist, is that the diagnosis of a major chronic physical illness is often a huge risk factor for suicidality in youth. So you find out that you have type 1 diabetes and you're insulin dependent. You find out that you have juvenile rheumatoid arthritis. You find out that you have multiple sclerosis. So you have something that dramatically changes your future. It changes your ability to exercise. It changes your diet. It changes your habits. It changes your social supports. So the new onset of a chronic and potentially debilitating disorder with long-term sequelae, that is something that we all need to take into account and to look for, does that engender in them hopelessness, worthlessness, helplessness, social isolation, and the rest of it. Next slide. Here we go, protective factors. And the basic thing to think about is that social isolation is a major risk factor. So attachment is really important to people, but one of the things I always like to point out is recovery from any kind of challenge, physical, emotional, whatever, means that we restore to ourselves a sense of meaning and value and purpose. And so it's really important. It's not just having a vague kind of hope for the future. It's being in touch with what's important to us, what we value, what we believe in, what we connect to. So we're not just talking about connecting to other people, an attachment to other people. We're talking about reconnecting and attaching to our own sense of meaning and value. Next slide. More on protective factors. Next slide. And what we want to emphasize in all of this is we want to support reasons for living and hopefully diminish reasons for dying. And this is just to alert you that the DBT and CAMS teams have developed an inventory of reasons for living for adults and reasons for living inventory for adolescents. It's really just a bunch of suggestions. It's not a questionnaire, but to let you know of the kinds of areas that you can elicit. So my friends stand by me whenever I have a problem. I feel loved, accepted by my close friends. I feel close to my family. These are just examples of close to 80 plus items to give you suggestions about what to pursue. Next slide. I always like to mention this too. I did a study a couple of decades ago, actually, of teaching hospitals in New York, and I looked at how child psychiatrists made a decision to hospitalize. And one thing that's never in our assessment, but that should be, is the level of supervision and care in the home. So for instance, if we use the Columbia screen and somebody is at very high risk, but they have a wonderful support system, very caring parents and siblings and friends, involved teachers and school nurses and school counselors, people who will monitor them well, will care for them, will make sure that they get the most excellent standard of care in their community and follow up if they're concerned, you might not hospitalize that person because they have a huge support network that's going to care for them. The opposite situation, you use the Columbia screening scale, et cetera, and you find they're at mild to moderate risk at most. But they come from a very chaotic, stigmatizing, challenging, if not abusive, environment, both in their community, in their household, et cetera. No one will support them being in therapy. No one will support them getting care. No one will monitor how well they're doing and report it to. So in that situation, their supervision and care is significantly lacking. Those folks we might hospitalize. So I really want you to take that into account. I think for a lot of us, we sort of do intuitively, but we don't document it and we don't explain that circumstance. So next slide. Risk level pulls this all together. Next slide. And this is probably all very apparent. If somebody has significant ideas, intents, plans, rehearsals, behaviors, they have a family history, and a personal history of lots of mental challenges, physical challenges, etc. And they've talked about previous near lethal attempts or rehearsals for them in the past, and they have multiple risk factors. Of course, they're high. If they have only the vaguest of ideas of wanting to harm themselves or not face the future, and they have none of these risk factors and a lot of the protective factors of community, family, support, inner resources, etc., at very low risk. I'm sure this all makes sense, or hopefully it does. Next slide. Now we're going to get into safety planning. I'd like to focus on this, and if it's all right with Veronica and Alicia, I know that we're timed through 11:15, but it took a little while for us to start. So, good. So I'm going to use some of that time to go over this content because I don't want to rush through it. It's important. Thanks a lot, folks. So the first part is recognizing those warning signs for that person. Remember those 5 major points, which I'm now going to review. And then we phase our safety planning in the stage-wise fashion, because what we want to start is what those people have within their own resources, their own competencies, their own skills, things they can do on their own. So we're starting with that because we want to say, look at all the things that you can do on your own, that you don't have to rely on friends and family and counselors and teachers to get through the day. Here's things that you've already been doing on your own to benefit yourself. Then you look at how they can connect to a friend, not for advice, not for counseling, not for crisis management, not even to vent. It's more to do pleasurable things, neutral things, to be out of that negative space. If none of those work, then you move to telling a friend, what you're struggling with. And then if they are unable to help you or feel overwhelmed and you feel overwhelmed, then you ask for help from professionals. At that point, we also interject the idea of reducing access to lethal means. And the reason we do that at this point, not from the start, is because now we've gone through this whole repertoire of possibilities for people, things they can do on their own, with their friends, with their peers, with their families, all the professionals that will help provide this safety net for them so that they have all these resources. And then we say, should you feel suicidal, here's the way to lower the risk that when you do, and it's usually impulsively, it's usually reacting to a particular stress event, you're less likely to die, because if you try to overdose with pills, they're less likely to kill you. If you cut yourself, etc. What we really want to look at is how to prevent something that in that moment you use and then you die, and wish that, in the milliseconds maybe that you're conscious, you wish that you hadn't. And then we talk about, as we always do with any kind of modality, how likely are they to use it? What are the obstacles? And before we say goodbye, we brainstorm all the obstacles that might get in their way. Very simple things like they don't have transportation to treatment, or that they don't know how to ask for favors from friends in a way that's not off-putting, or they can identify who would be helpful to them and who not, who's safe and who's harmful to them. All those things we want to help them with. And we end with, what did you learn about our discussion today as the major reason why you want to go on? What is your primary reason for living? So you see, progression is very intentional. Now I'm going to briefly sketch this out. And again, you'll have at your leisure to look through the PDF to get all the details. So next slide. Next slide. So this is a safety plan template, you'll see all these spelled out for you so you don't have to read the small fine print. Next, Veronica, next couple of slides, and then we'll have all these pop-ups coming out. So you can see what the point is what are your early thoughts and feelings? What are your warning signals, warning signs? Remember that. What are some techniques that I can do by myself? What can I do to, who can I call to help me? The call, my friends, right? Who can I call for help? Tell someone. Who can I connect to professionally? And then reducing access to lethal means, medicines locked up, guns removed, sharps locked, alcohol locked up. And then finally, we end up with the reason for living. Next slides. And that is, sorry, go back one more slide, Veronica. There it goes. What is the most important thing I need to remember about why I should live? That's the reasons for living piece. Next, thanks. So here's another way of framing this. Next slide. And the warning signs, we're going to whiz through these ones because I just pointed them out. Next slide. Here's advice about on my own coping. Next slide. And that's subdivided between distraction, soothing, and physiological. So some people, reading, music, dancing, writing poetry, playing video games, watching something on the screen, repeating songs, poems, all sorts of ways in which we pull ourselves out of that negative space. Soothing, this is like aromatherapy, being out in nature meditation. Physiological is intense exercise, aerobic exercise, muscle relaxation, deep breathing. All those things can pull us out of this area of difficulty and concern and put us in a neutral, calm kind of space, if not a pleasurable kind of space. Next. I always like to emphasize this, that in this very big poll run by major suicide prevention organizations and coalitions, 94% of people believe that suicide can be prevented, and the same large group of people said they would try to help. So this idea of no one cares, everybody's hopeless about suicidality, no one wants to be involved, not true. So we can create these safety plans with the conviction that there's a lot of people who really want to be of help. Next slide. Then with a friend, we talked about that, getting out, telling someone that you're having difficulty. And this is, by the way, where community gatekeepers, natural helpers, etc., come into the picture, people who've been trained in mental health first aid, where we have community caregivers who know how to elicit this kind of information and then refer them to professionals who may be of help if that person is really under distress, which is our next slide. Contacting professionals and agencies to ask for help. You should all have this handy, especially the New Mexico Crisis and Access Line. And one of the things I think that you all know about, hopefully, is that youth have the ability to text with peers if that's what they prefer. So there's all sorts of ways to connect people other than behavioral health professionals in behavioral health agencies. Next. And then reducing potential for use of lethal means. I have a lot of detail about that, but I want to get to the final piece about discharge planning. So Veronica, we're going to whiz through a bunch of slides. Next one, next one, next one, next one, next one, next, 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 next. And after that, next. And again, we want to focus on reasons for living, using motivational interviewing to do that. Next slide. We're getting there, folks. Keep going. Keep going. Keep going. This is about My 3, which is an app for safety planning. Give you all the steps. Next. Next slide. Here we go. We're there. Back one slide. Sorry, I couldn't control this for you. But the issue is that discharge planning is really critical for that information that I told you about to supply to people out in the community, to the families and to the youths themselves about what is the plan. So I like to cite Oregon because they did a wonderful thing. They created a rule by law by the state legislature where hospitals to be accredited when they did discharge planning in their emergency departments had to include a bunch of information to document what this was, and especially document the treatment plan and the referral plan. So the identified patient, their family, their supports, and everybody who was welcoming back into the community would know why those decisions were made, what the plans were for follow-up, etc. So you have this information here. Next slide. And that we're going to go into a little bit of detail. So you conduct a behavioral health assessment, and it needs to go into that detail that I mentioned earlier when we were talking about the suicide and risk assessment. We don't want to just have this message, which we often get, as you know, in the schools and in provider agencies, that the youth was seen, well, we don't know who, they determined that they didn't need hospitalization, and we don't even know that they're coming back to school the next day. There's no plan, there's no information. So this is very detailed information about what assessment was made. So for instance, did you know that they looked at supervision and care? Did you know that they looked at risk in general, not just whether or not they, quote, admitted to suicidal ideas and plans and attempts? Next, that they coordinated the patient's care and transition to outpatient treatment, and how to do that, how to share that information, how to release protected health information under certain circumstances, so that communication moves forward. It doesn't just stay in the chart of in the hearts and the minds of the emergency care providers. Next. So the information to share with the patient, why they were initiating discharge, what was the diagnosis, what were the treatment recommendations, what were the safety issues that need to be addressed outpatient, what was the safety plan, did they go through the safety plan in the way that I did with you, was that youth given and their folks given a copy of that? Did they use like a My3 app, which you can edit on the phone, that they can keep with them and modify? And part of that safety plan is, what professionals are they seeing? What supports in their family and in their peer group will they utilize? How will they utilize them? What is the reason for living? If there was newly prescribed medication, what's their indications? Why were they given? What's their dose? What's their side effects? Truly informed consent, right? And when to seek immediate medical attention. If this is happening to you, if you have these warning signs, if something is going on that's really worrisome to you, you've exhausted your own resources, your friends' resources, etc., and you can't reach a helping professional, it's late at night, offices are closed, when do you need to call 911? When do you need to call the New Mexico Crisis Access Line? When do you need to call Agora, etc.? This should all be spelled out. And the reason I cite Oregon is it has to be spelled out. They provide this template, and that's part of chart review, that's part of accreditation. My hope for all of us is that New Mexico finally creates a suicide prevention plan that they have to report to the federal government, and that the state legislature backs legislation like this, so that all of us have the assurance that somebody gets a really good assessment when they go to urgent or emergent care, and that all of us in the community get this kind of highly important and useful information. So if, like in Peter Pan, if you can all clap your hands and Tinkerbell will stay alive, if we can get the state to move in this direction, Oregon, after passing this, showed a 32% reduction in fatal suicide attempts. So this is true public health prevention. Next slide. So there are evidence-based therapies to look at underlying vulnerabilities. I skimmed through a slide about suicidality-specific therapies, which I and Laura Rombach will be having the privilege of joining you about next month. The Collaborative Assessment and Management of Suicidality Model, and Cognitive Behavioral Therapy for Suicide Prevention. So now I'm really over time. So if you have, I'm going to turn it over to Veronica and Alicia to talk to you about your CEs. But again, you have my email address. Please feel free to write me for future references.